Hello and good evening, everyone, and welcome to another event by the Goldfarb Center for Public Affairs at Colby College in Maine. Tonight, we're going to be talking about how the pandemic has exacerbated disparities, talking about deepening the divide. We know that in our audience, we have parts of the Colby community. We have students, we have parents, and we have faculty and staff and alumni. But I know we also have a broad audience of Mainers who care about these issues as well. So you're all welcome. This is one of our last events of the semester. Our next event is having a conversation with Homeland Security Secretary Ali Mayorkas in about 2 weeks, so pay attention to that. Tonight, we have a great panel of some good friends of mine talking about this issue from a lot of different angles. We're talking about things from misinformation to vaccine access. We're going to be talking about how these disparities that we have gotten deeper and wider, and most importantly, what are some of the solutions to these divides. And we're going to talk about a range of disparities. So I definitely want to touch upon the racial inequalities in our own country, but also looking at the stark differences that the pandemic has had on, say, wealthy versus more poor nations. And to talk with us tonight, we have a great panel of experts. I'll introduce them as well as my student co-moderator, Josue Gonzalez. So first, to talk about our speakers, the first speaker I want to introduce you to is Dr. Lisa Fitzpatrick. She often goes by Dr. Lisa. I might refer to her as Lisa or Dr. Lisa throughout this. She's been a friend of mine for, good Lord, I don't know, 15 years probably. She's an infectious disease doctor who worked for a decade at CDC. She's also been an associate professor at Howard University. She's now on faculty at GW, George Washington University. But probably most relevant to our conversation today is she's the founder of a health literacy organization called Grapevine Health, which I'm sure she'll tell us a bit more about. And then moving on, one of our next speakers is Steve Morrison. Steve is a colleague of mine from the Center for Strategic and International Studies. He is a senior vice president there and a director of the Global Health Policy Center. And those are his formal titles, but I would probably describe Steve as a policy shaper. He's a podcast host and he's a prolific writer. And I would also call him a mentor to me because he's really understands how DC and policy works and is going to be able to help us unpack that as it relates to this issue that we're talking about today. And last but not least, we have, of course, a Colby professor joining us, Professor Nadia El-Sharawi. Nadia is an assistant professor of global studies here at Colby College, and she's also a member of the Goldfarb Faculty Advisory Committee. She's a cultural and medical anthropologist who also has a degree in public health, and she teaches courses on refugees and migration, humanitarianism, and global health. And she's going to be able to look at this from a global context as well. And now, super proud to introduce Josue Gonzalez. Josue is a member of our Goldfarb Student Executive Board. He is a sophomore. He comes from Houston, Texas, which has been hit hard by the pandemic. Beyond being on the Goldfarb Student Board, he's also a member of the Pew Community Board here at Colby, which supports students on campus that come from marginalized communities. So, Josue, let's turn over to you. How should we start our conversation this evening?
Thank you so much, Kimberly. First, I want to give everyone a warm welcome. I hope that y'all are doing well. The first question that I wanted to ask was, in your work related to the pandemic, I know all of y'all come from very different backgrounds and perspectives. Which kind of disparity has your most immediate attention?
I'll start. That's such a provocative question for me because I think there are so many different disparities we've seen throughout this pandemic. But because, there's a saying, where you stand is where you sit. And because I focus on health literacy, helping people gain access to trusted health information through my company, Grapevine Health, I'm most concerned about people having access to trusted health information so that they can make a decision about whether or not they want to be tested, and right now, most acutely, whether or not they want to be vaccinated. So in having conversations about the vaccine, we are continuing to see some access disparities with the vaccine. So that's of great concern to me. And I hope we'll be talking a bit more about that. And I should have said, I just want to thank you all for having me here today. I'm looking forward to this conversation.
Shall I jump in and say a few words? From where I sit, there's two major things that jump out in terms of inequities and disparities. One follows on what Lisa just said, which is we're in the midst of a national trauma unlike anything that we've experienced, certainly since World War II, perhaps as far back as a century. And this pandemic trauma has just cut through our society and worsened and aggravated all the pre-existing disparities, whether they're according to race. The Black, Hispanic, Native American populations have been deeply, profoundly impacted, whether it's about gender, whether it's about poverty levels, economic status, whether it's rural versus urban. There are multiple dimensions where we've had this problem manifest. And it's something that has, I think, really alarmed everyone here who has witnessed this. And it's begged these questions like Lisa's focus on. We have to, people who are distrustful of our medical system, distrustful of science and authorities, fear perhaps that a vaccine has been developed too fast or the like, they have legitimate questions. They have to be engaged, they have to be treated respectfully. We also need people to come forward and get vaccinated because that's so essential to getting out from underneath this pandemic, reopening society. We can talk more about the levels we've achieved, but it's tough because we have a lot of distrust in our society, much of it quite legitimately based on historical mistreatment and abuse. And so we're having to reckon with this. Of course, this happened also in the midst of the racial strife and disorder that we have experienced after the murder of George Floyd. So that was added on top of all of this and added additional elements. The second piece is the more international one that Kimberly referenced, which is that in order for us to fix the pandemic, we cannot ignore what's happening outside our country. And that what is happening outside is complicated, fast moving, and very dangerous. And there's a huge disparity between what is happening here in terms of vaccine access and investments and the like, and what's happening outside. And we can come back and talk more about that. Thank you, Kimberly. Thank you, host Sway. Thank you to Ian Murphy for putting this all together. Great pleasure to be here today.
Nadia, what are your thoughts?
Yeah, I just want to echo, thank you so much for including me in this incredibly important conversation. And Josue, I agree. Excellent question, really difficult question, because it all feels important. And I think one thing I will say is to just agree with Stephen and Lisa that one of the things that's most on my mind right now are questions of vaccine access. Particularly, I don't deal with this as much in my own work, but a lot in my teaching, especially of course this year, teaching on courses on global health. We've been talking and thinking a lot about access to medicines, access to essential medicines, and particularly access to the vaccine and the ways in which that's incredibly inequitably distributed, both of course within this country, but most pressingly on a global scale. And then in my own work, very concerned with disparities around migration. And I know we're going to talk a little more about that, so I'll leave that for now. And then the other thing that I would add to this conversation is, for me, what is most important are the ways that the structural determinants of health, and Stephen, you talked about these already a little bit, so I'll leave that for a second, but the social conditions, whether that's systemic racism, socioeconomic inequality, and of course the ways that all of these intersect with one another are the most important to address. Because while I think it's often very tempting to look for technological solutions, to look for behavioral solutions. And of course, those things do matter and are really essential. For me, knowing that that this is sadly, even though I shouldn't say this because I think we're all looking for the end of the tunnel, I know that this is very unlikely to be our last pandemic, to be our last epidemic. And so for me, what really matters is addressing the things that are going to help us with the disparities right now for this pandemic, but also carry us forward into a better situation when the next one comes.
Thank you all. As we think about that, Nadia, I always go into policy thinking like, okay, so how does this work? If you're in Washington, D.C. at that level or even down to the local level, but let's start with D.C. first. So I want to go to you, Steve. Let's talk about the Biden administration and where are some areas of strengths and weaknesses in terms of how U.S. leadership has responded to both what Nadia was talking, sort of those immediate things as well as those long-term things. And can you talk a little bit about the COVID-19 Health Equity Task Force that was created under Biden?
Okay, thank you. I think it's important when we talk about all of this to remind everyone of what happened on day one of the Biden administration, January 20th, because it was unprecedented and it was sort of startling. The president was inaugurated and it was revealed that there was a 200-page action plan for addressing COVID in the United States that had been prepared by a team that went to work day in, day out, starting in July of the previous year. So we had a 200-page action plan. Then there was a COVID response team stood up at the White House with very competent folks. And then there were 13 executive orders signed, 3 presidential memos, and the first national security directive. Within that were all sorts of steps that focused upon equity and focused upon addressing disparities. You had the Domestic Policy Council created under Susan Rice with a special focus on racial equity and that as a central portion of its mission. You had the COVID task force the COVID-19 task force on equity created under Professor Marcella Nunez-Smith from Yale, and it was charged with implementing the strategy. I'll say a few words in a moment about that. You also had the Gender Council eventually created later in early March under Jen Klein as the executive director with a charge of achieving across our government gender gains in a way that's unprecedented as well. On the COVID response and Marcella Nunez-Smith's strategy, what was most important, I think, other than staffing that up and putting it within this robust and strong structure within the White House, was that soon thereafter, there was the passage of the American Rescue Plan, $1.9 trillion plan, which included $400 billion dedicated to different portions of the COVID response. And within that, over $10 billion dedicated towards outreach at community level and local level in support of the strategy. You had $6 billion committed to community health centers. These are mostly rural centers where you have, to get back to what Nadia was saying, you have populations that are the most marginalized, disadvantaged, those that are the least connected to the health system. You have $6 billion dedicated to 1,400 of these community health centers as a key instrument of reaching those populations, Black, Hispanic, Native American, impoverished, those with chronic underlying conditions who are too poor to access the community, underserved communities. You had $3 billion dedicated towards vaccine confidence. And that meant trying to improve both access by people who are less connected and who are struggling with, how do I access the facilities? How do I get there? How do I know when I can get there? How do I register? How do I access the instruments in order to get there? Plus the whole issue of equitable use of all of this. And that $3 billion is going out as awards to 64 of the major jurisdictions, the states, territories, urban centers, for onward to the local health communities. We also have community health workers being hired in order to go out and do the localized retail walking around communities and finding those people that we need to find who may be hesitant, who may be not connected and with little access. And that's $350 million that are going towards that. So Marcella Nunez-Smith came in with the charge to coordinate the strategy. The 1.9 trillion brought the resources forward in order to charge up the institutions that should be leading this process. That's a fairly simplified way. We can talk also, President Biden yesterday unveiled a number of changes in the US approach on vaccinations, which are moving towards intensifying the localized approach. And we can talk, I don't want to talk too long, but we can talk about what that all means. I know Lisa and Nadia are paying attention to all of those changes as well. Thank you.
Dr. Lisa, I wanted to ask, in your experience working directly with communities in DC, have these policies truly addressed existing disparities?
Thank you, Josue. That is such an important question. And I was thinking about that as I listened to Stephen describe all the budget allocations, the policies that have been enacted to support vaccine access, COVID pandemic relief, and so on. And it's interesting to me, there's a disconnect. And I think there's always been a disconnect between government and the people on the ground, the people working on the ground and the people we are serving. And I'll just give you an example. Just 2 weeks ago, a woman called me who leads one of our federally qualified health centers. And she said, I know you all are doing a lot of work on the ground in the community. Can we work together to figure out how to improve vaccine access and uptake? Because we have vaccines, but we can't get our patients to take them. And I think it's laudable that there are resources available for these sorts of things, community education and engagement, but the money is often tied up in ways that we can't readily access it so that I could be responsive to a request like that. In addition, I was in Detroit just 2 days ago I provided or led 3 town hall meetings with a group of factory workers in Detroit. And as you may have seen in the news, Detroit and the state of Michigan has been fairly hard hit by the pandemic. So similar issues, low uptake of the vaccine, and the questions people were asking were very basic questions. By now, we've heard a lot of these responses, but somehow the information is still not flowing through. And I think it's because of the absence of trusted messengers. They were asking questions like, what's in the vaccine? How do you know it's safe? What are the side effects? And we've been talking about these vaccines for months now, answering these questions, but somehow the information isn't being filtered through the right channels. And I think the funding we just heard Stephen talking about has to somehow be more strategically directed or allocated so that it actually reaches the people like that who need to get vaccinated. And I think the final observation I'll share with respect to what's happening, not just in DC, but in other places, and that is, I think we have to better engage young people to understand they also have an impact here. And I've had young people, I'm talking 20-something, say to me, well, you know, is coronavirus really real? Where did it come from? And I don't know anyone who has coronavirus, and they're not thinking about the impact they may have on others in their family or even people around them who may be at high risk. So I would love to see in the coming days and weeks that we find more efficient ways for funding to flow to a lot of these trusted community organizations so that we can address some of these knowledge gaps and the distrust we continue to see. You know, I know it's hard for the government to directly fund some of these trusted organizations, but we have to find a way to do better and eliminate some of the barriers associated with getting the resources on the ground we need to end the pandemic.
Nadia, I'd love to hear your thoughts in response to anything Steve and Lisa just said, but I'd also like to pivot a little bit, still talking about Biden and US leadership and policy, but thinking a little bit more about how we're seeing that impact on the border. When we think about detention centers and the influx of folks coming across the border since this administration came into office, and how that is playing out in your mind, Nadia.
Yeah, thank you, Kimberly. Yeah, I have a lot that I can say about that. And one thing that I would say is that we, of course, we've had this change of administration in the middle of the pandemic. And Steve and Lisa, you've done such a nice job of talking about the changes. But what I think is really important is to remember is that a lot of the immigration policies in particular that were put in place before the pandemic really exacerbated its effects and caused unnecessary suffering, illness, and death, and a lot of fear. And that fear continues. And so the example of this that I think is the most commonly talked about and is a really important one is the now defunct expansion of the public charge rule under the previous administration that ruled that people who might become dependent in the future on government services would be excluded from US visas and permanent residence. And this came into force February, I think 24th, perhaps, that might not be the exact date, but 2020, so right before the pandemic, and was finally halted in March 2021, but did tremendous damage in the meantime during a time when immigrant communities were particularly vulnerable. And so we saw a lot of effects where people were really afraid to access any kind of services, even ones that they were entitled to, even ones that would in no way trigger this public charge rule, put it into effect. Nonetheless, it kept people from accessing needed medical services. And then, just like you said, immigration detention and deportation are particularly important problems here. And what I'll say just in terms of big picture, thinking about in this country, and we can also talk internationally as well, but maybe I'll start just here, is that the pandemic has really affected every aspect of our immigration system, whether that's just the issuing of visas, whether that's the refugee resettlement program, whether that's the situation at the southern border. Everything has been affected. And of course, we've had under the Trump administration that was so intensely anti-immigration in every way. We have those kind of effects coming into each other, right? Affecting one another. So in terms of detention and deportation, the Marshall Project in the New York Times tracked more than 200 deportations and found that people were being transferred to different detention centers, sometimes with COVID, and being deported from the United States, either with COVID or their status was unknown, and then testing positive for COVID shortly after deportation. So early in the pandemic, there was this documented effect where ICE and deportations were actually potentially spreading COVID outside of the United States. And then we have the situation in immigration detention itself, where we have a lot of criticism and cases working their ways through the courts right now, talking about how within ICE detention, there's inadequate oversight, claims of medical neglect and abuse, lack of access to sanitizing equipment, to personal protective equipment, to testing, to care. Within a lot of these facilities, which are, some of them are public, some of them are private, social distancing is not an option except when people are put into harmful isolation, right? So a lot of the times when people are test positive for COVID, or even sometimes when they're just waiting for results, they get put into solitary confinement, which we know is a very harmful thing for somebody to undergo. And despite what we know about these dangers, ICE continues to transfer people into detention, and importantly, to transfer them between facilities. And the other thing that we know is that this, of course, doesn't just, I mean, it's enough that it affects people in these facilities, but we know that it, of course, affects surrounding communities, right? There are people who work in these facilities who come into them and then go out of them into their communities. And so the situation within detention centers is one that is problematic. It has been not sufficiently discussed has not been sufficiently, it's not sufficiently transparent, and it's a really serious situation. And it echoes in a lot of ways, speaking of disparities, what we've seen in other congregate facilities, especially of course prisons and jails, but we actually see the situation is worse to a certain extent in some of these detention facilities because there isn't the same kind of standardization and oversight that we have even in prisons where the situation is as we all know, really, really quite terrible. And I think I might, so as to not talk too long, just leave it there. But the other thing that I think is really important, if I can take just a second, is to talk about, and Lisa, your point made me think of this, to talk just a little bit about immigrant workers and the ways that they have been disproportionately affected by the pandemic. Immigrants are more than other populations work in circumstances in which they've been unable to, work from home, unable to decide not to go to work. There's a story that I read recently about workers in a crawfish processing plant in Louisiana who left work to seek medical care when they began to show symptoms of COVID, and who were subsequently fired, and their employer reported them to immigration. And so you see the sort of cascading, going back to that, what I talked about earlier about structural determinants, you see that cascading effect, right, of you get sick, you lose employment, you lose housing, you lose your immigration status. And those are the kinds of interlocking vulnerabilities that immigrants and refugees face in this country.
Thank you for your response, Nadia. I think it's honestly heartbreaking to hear about how a lot of very vulnerable populations in this country aren't being given adequate resources. And I just would like to kind of pivot the conversation towards other vulnerable populations in other countries. Steve, if you could speak on that, that'd be great. Just about how the pandemic has affected other vulnerable populations in other countries and what the US can do to help.
Thank you. Thank you very much, Josue. Well, this is a big day on that question because the U.S. Trade Rep, Catherine Tai, who's been deliberating on with the head of the World Trade Organization, Ngozi Iweala, announced this afternoon, just a short while ago, that the U.S. was going to support the waiver of patent protections. And that's a very big step and a bit of a surprising step, and one that's going to generate enormous debate. But it was what was driving it was, in the words of Catherine Tai, the U.S. Trade Rep, was we're in the midst of this profoundly colossal global pandemic, and we have inequities around vaccine access that are dangerous, truly dangerous, and we have to take extraordinary measures in order to begin to address this. And you can look back at the onset of the pandemic in terms of who had access to protective gear, PPE, to oxygen, to ventilators, to all of the other elementary items needed for the response. There was great inequities in the markets, in the ability to access these, and the ability to purchase them. And the markets were distorted, heavily distorted. We also saw, to get to your point, that the pandemic struck low and lower middle income countries with a particular ferocity in terms of undermining their economies and creating the risk of fiscal collapse. Many of these countries are operating with excessive debt, and they don't have the ability to generate their own funds the way wealthier countries generate their own financing. So this has created enormous suffering. A lot of governments moved early on with fairly strict lockdowns. And I think you can argue that in Africa, in particular, you had a pretty sweeping set of pretty tough lockdowns introduced in the spring months of 2020. And they delayed the onset and had some significant impact in curbing transmission, but they had huge huge consequences in terms of the suffering and economic dislocation of the poorest, those who were at the bottom of the pyramid, who did not have the ability to find a social safety net, did not have the ability to distance from one another, were living day to day by their income, and they saw their opportunities collapse. That caused, great caution in reimposing this. If I can shift for a moment to India, in India, there was a 2-month really severe lockdown introduced last spring, and it did stop transmission, but it dislocated over 200 million itinerant workers who had moved from the rural countryside into urban and peri-urban opportunities, who suddenly found themselves basically cast back out onto the terrain to find their own way home in desperation. That was a heartbreaking and really pretty stark reminder of what happens in the midst of a pandemic like this. And when you look at where we are right now, where the India is going through this runaway pandemic, in which we're having reported 400,000 cases per day, actually much higher in reality. The death rates of 3,500, much higher in reality, and completely out of control. How did we get to that point? Because that is hitting all sectors of society, but particularly those who are the poorest and most marginalized and least protected. Well, it was the reality that after those tough lockdowns, their complacency settled in. There was a relaxation of protections. Political leadership concluded no more lockdowns, not sustainable, but also didn't attend to the preparedness issues, including getting vaccination programs underway, but also preparing for the second wave, which people erroneously assumed was simply not going to come. So it was a leadership failure, it was a preparedness failure, and now India finds itself in a catastrophe. And it's really worrying all of its neighboring states, who also have large populations with uncontrolled transmission and weak preparations and weak public health infrastructure. And the most vulnerable are those that are the poorest and least protected. Thank you.
I have too many thoughts in my head, because I want to turn to Nadia, because I know she'll probably have some more thoughts thinking about global, but I'm also can't have it out of my mind, like thinking both Lisa and Steve have spent a huge amount of their career working on the HIV pandemic or epidemic. And like, why haven't we learned some things from that? There are disparities created there. Is there anything that's been, learned as far as solutions? So I know that I just threw a lot at you. So why don't we start with Nadia, just because I'm curious if you have more thoughts from the global perspective. And then I'd like to turn to Lisa to go from global to local and see if there's any HIV discussion and lessons learned that we can point to. Nadia?
Yeah, well, I actually can, I'm excited to hear both Lisa and Stephen talk about the HIV pandemic, but I can even step in and say a couple of words about that. One of them, which is something that we've been learning about in my class quite a bit, and I've been thinking about a lot, is the tremendous fight to get access to medications for HIV/AIDS, both in the United States and abroad, and the incredible role of social movements in that fight, in both getting those drugs developed and then in having them be accessible. And so that's something that I think about a lot. And when I see like the People's Vaccine Campaign, for example, it really reminds me of it comes directly out of the larger fight for access to essential medicines worldwide. So I think you're really picking up on something important, Kimberly. And then the other thing I would say, thinking about the HIV/AIDS epidemic is, and then I'll connect this a little bit to sort of my area, which is refugees and displacement, is the other thing that we saw with HIV/AIDS, particularly in Africa, was the ways in which people were not, the ways in which sort of prejudicial ideas, discriminatory ideas about populations and about their abilities to act in their own best interests, really infiltrate global public health at various moments. And so we saw that with HIV/AIDS epidemic, where there was this idea that, oh, antiretrovirals are so complicated, you have to take so many pills, there's no way these African people are going to be able to do that. And then actually, of course, once that fight for medications is successful, what we see is actually we have higher rates of compliance for medication use in Africa than we do in the United States, for example. So I see that as well with COVID. And one way that I see that with COVID actually is in my own area of work around displacement and refugees, which is that but with an ironic twist, because when the pandemic started, everyone, including myself, thought this is going to be awful in refugee camps, right? Because access to PPE, ability to socially distance, access to sanitation, all this talk about constant hand washing. How do you do that in contexts where, regular access to water is not necessarily available and can't be taken for granted? But what we've seen is that the numbers are lower than expected in refugee camps, which is a really good thing. And it comes from good and bad places. So the good place is related to the HIV example that I gave you, which is that we don't give people enough credit. And I really love the way, just at the very beginning, Lisa, when you were talking about the work that you do and the health literacy work, you talked about giving people access to the information. And I thought that was just a really important move rhetorically, right? To say, it's not that these people don't know things. It's not that they're not smart, they can't figure it out. It's just this question of access to information and that those trust relationships, exactly like you were talking about earlier. So what we've seen is that actually people have stepped up here in Maine, in the United States, and abroad in lots of places. We have refugee-led organizations doing really tremendous work to keep people safe. And then the other thing is the bad piece, which is that refugee camps tend to be isolated. And in a lot of places, people aren't legally allowed to work. And so some element of the protective factor that we're seeing is actually probably by virtue of that isolation. And so that's really not something to be celebrated. But yeah, I mean, it's interesting. And I would say that thinking more kind of broadly about displacement and migration and outside of the United States, we see really sort of mixed outcomes. But I'm glad that you brought us to the HIV/AIDS epidemic, Kimberly.
Lisa, your thoughts?
So many, but it's an interesting parallel to consider, the HIV epidemic and what we're seeing now with this pandemic. We've been talking a long time about disparities related to HIV transmission, access to treatment, and so on. It's as if history repeats itself over and over again. So when we think about the notion that there will be another pandemic and what can we learn from what's happened in the past, unfortunately, and I tend to be very skeptical about these things, I don't know that we'll be prepared for the next one, because there are some things we could have learned about messaging. I would say messaging and communication is a big one. There were so many communication failures, I would say, during the HIV epidemic, but also, HIV is still with us and we're still failing to communicate effectively about how HIV is now a chronic treatable health condition. So turn to COVID, we're hearing a lot of the same themes in underserved communities we're working with related to COVID. Somehow COVID-19 has become stigmatized. So people are afraid to tell people, not necessarily for immigration related reasons, but because they don't want the shame and the judgment associated with having COVID, when it's actually a health condition that is through no fault of their own. But I also, back to the communication piece, from the beginning, we have not done a good job, include public health leaders, the White House, politicians, whoever's talking about COVID-19, TV doctors. There's so much misinformation, not necessarily misinformation from the experts, but the communication, it's not clear. And so it feels confusing to the community. So we need a better strategy to communicate information in a way people understand it. in a non-judgmental way. And so for me, these parallels between HIV and COVID really are related to the way we communicate public health information, and also what can we do to reduce the stigma associated with having a health condition. And I think in the health system, we are also part of the problem, because we often are judgmental towards our patients and the people we serve, and they can feel that. And I think it further erodes the trust. And we're seeing now the impact of that on the impact of our failure to communicate in communities. And I also, on this communication piece, I'll just say, we've talked a lot about trust and distrust this, and why, particularly the Black community, why is there so much distrust? And the question is, what have we done to actually earn the trust over the years? And the worst time to try and gain trust is in a public health emergency, which is what we've been trying to do. And it's even harder because there's so many competing demands on people's time and interest. And so I like the question, but I'm struggling to think of anything we've learned from past experience that has really enabled us to move forward. I would love to hear Steve's answer on this in case he has some positive thoughts about this.
Okay. A couple of points I think about, what's the meaning of HIV in the current response. First thing I'd say is, we suffered a dangerous, terrifying HIV pandemic, 80s, 90s, into the not decade. We have not ended this pandemic. We have no cure, we have no vaccine, but we did bring it under control to a degree. There's 26 million people on antiretroviral therapy. There's another 12 million that are not on therapy. So we haven't fixed this problem, but there were some pretty searing experiences in the 90s and into the not decade, particularly when you had antiretroviral therapy come forward in 96, but only available for the rich. And it took 5 years of struggle in order to get to the point where you had PEPFAR launched, the President's Emergency Plan for AIDS Relief, the Global Fund launched in 2002, 2003, and you had financing, and you had production agreements to drop the price, move to generic licensed production, begin producing millions and millions of antiretroviral therapies. So there was this historical experience where US leadership was at the front end of mobilizing to address this problem, particularly in Eastern and Southern Africa. The people who were leading that effort at that time are people that are still in prominent positions today, guiding the COVID response today. Tony Fauci has been involved in HIV since day one. When this was first discovered, it'll be 40 years this June when we had the first notification in the United States of this disorder. Tony Fauci, Deborah Birx, who's no longer in the government, but she's a very prominent HIV leader. Rochelle Walensky, the head of CDC, her career has been built upon brilliant work in HIV, and on and on. Robert Redfield, who headed CDC, and others. The other thing that I think came out of that experience was we cannot, in this pandemic, which is even larger by multiple times than what we experienced with HIV, and HIV looked terrifying in the 80s and the 90s and into the not decade. What we face today is on another scale, and I think what we're seeing is a perception coming forward for those who lived through this pandemic earlier, the HIV, that we cannot wait around 5 or 6 years to try and find solutions. Things are moving too fast and at too dangerous a scale. And of course, India today, the tragedies unfolding there on such a colossal scale back up that point pretty dramatically. Other point I'd make is that our investments, the US-led investments with others in PEPFAR, in the Global Fund, and us, we've invested over $100 billion in HIV programs, principally in Southern and Eastern Africa, not exclusively, through our own bilateral PEPFAR program, through the Global Fund. As I said, 26 million people sustained on antiretroviral therapies today. Those infrastructures created some resilience in those communities in the midst of COVID. There's a debate going on as to how much damage did those programs suffer with the disruptions of supply chains and with the diversion of staff, with people being unable to get to clinics. There's obviously been lots of damage and dislocation, and people are worried we're going to see a reignition of the HIV pandemic, as well as tuberculosis and other infectious diseases that have been neglected and need to be reset in this period. But we're also able to look with some pride at those investments gave us certain resilience and infrastructure that was very helpful in this period. The last point I'd make is we now face a situation where we have to prepare ourselves for the coexistence of two pandemics that are very different from one another. HIV, still no vaccine, no cure. 70 million people have been infected. 35 million people have died. It could reignite if we're not careful, but we have to continue down that road with HIV. But now we're looking at COVID becoming endemic. And what does that mean? And how are we going to deal with two coexisting pandemics, quite different from one another, but we've got to be able to deal with both at the same time, and we can't ignore either. And we haven't really come to terms with that. Thank you.
I would like to ask Stephen a question, though, around the endemicity. So I think this is a bit of an open question until we can see how, we need to get as many people vaccinated as soon as possible. I see this as a race against the clock. Yes. So if we get enough people vaccinated so that the curve flattens enough and we're close enough to zero, this is my wish list, that we don't get to a point that this becomes endemic. But some people feel it already is and it doesn't matter. So I'm just curious to get your perspective on that. Is it a foregone conclusion that this SARS-CoV-2 will be with us and we're just stuck with it?
Well, here in the United States, it's interesting that our leadership on the COVID response are moving away from talking about herd immunity. They don't want to talk about herd immunity. Herd immunity, we're not sure exactly what levels are required in order to say we have ended transmission and we have crushed this and reached a level where it's not endemic. That somewhere between 70 and 85, given the variants that have emerged, we're probably talking about 85. People are now saying we're not going to get to that point. And why are we not going to get to that point? Well, we have at least 20 to 25% of our population who are pretty hard over, not willing to accept vaccinations. And that fact alone is leading people to be pretty realistic and cautious here in our own society. And when you look at the patterns of coverage across many of the southern states, which have weak infrastructures, have had pretty poor performance in getting their coverage rates up. That doesn't tell me we're going to see containment or actually driving down to herd immunity and control of the epidemic anytime soon. Quite the opposite. I think we're heading into a situation where there will be high coverage, but high maybe 60 or 65%. Right today, we have 56% of American adults that have had their first dose. And we're hoping that we can get that number up to 70% by July 4th, first dose. That would be 171 million people. That's still not good enough for this kind of controlled coverage. So I think I'm of the opinion this is going to be endemic, and we're talking just the United States. We're not talking about, the places that are looking to have the best control are the UK, Israel, United States. Europeans are lagging far behind. And then you've got this vast number of states that have very little control and very little prospect of moving rapidly in vaccinating. And we are going to have to address that. So I think it's wholly plausible and very, very probable that we're heading into a world where we're going to have it's going to become flu-like. We're going to see winter spikes. We're going to have to prepare ourselves to be wearing masks and seasonally. We're going to have to prepare for boosters or new vaccinations against different variants. And we're going to have to live with the prospect that there's going to be reignition. One last point. In order to get to the point that Lisa's suggesting of control, we need to get below 10,000 cases per day in this country. Last spring, we got to 20,000. We reopened prematurely. We relaxed the controls and we shot up to 65 or 70,000 in July. We brought that number down a little bit. We got up to 330,000 January 8th. Where are we today? We're at about 48, 49,000. We are driving that number down, but we've been plateaued between 50 and 65, bouncing up and down now for 6 or 8 weeks. Why is that? Why can't we get deeper in the reductions? Well, it all has to do, in my mind, with behavior. And the variants don't make things easier. 116, the UK variant, 1117, the UK variant that is prominent now in the United States. It moves faster, it kills more. Our vaccines are pretty good against it, but when you talk about the race that we're in against variants, we're facing faster and more deadly variants every day that are emerging out of populations, large populations with uncontrolled transmission. And those variants don't have to start here in America. They can start in South Africa, in India, anywhere where you have large populations with uncontrolled transmission. You're going to see more variants generated that we have to deal with. And we're already facing that today when we look at what the race that we're in. So I do believe that we will achieve some success in getting control. I'm not arguing about giving up or saying we're doomed. We're not. But I don't think, I think the nature of this virus, which is so pernicious, the failures of controls and behavioral restrictions in our own political culture, in our own political system, and the fact that you look at the bigger global picture, it leads to a great deal of caution around what we're sailing into in the next few years. Thank you.
We've got a couple of questions from the audience. So Josue is going to look at those and pick his favorite, and probably this will be our last question. Josue, over to you.
Yeah, thank you. Duncan Gibson's question actually caught my eye. They wrote, how, I guess, do we take care of populations in Brazil and other nations where the leaders don't believe or care about the existence / risks of COVID-19? And I guess also, like, how does that play into like the larger global initiative to flatten the curve?
Who wants to kick off that question?
I think that's a great question for Nadia.
I don't know if that's it. Can you do that? Is that fair? Thanks.
There are no rules. Everything's fair. It's
all
Zoom.
fair. No, I think that's a great question. And I'll try my hand at an answer. And please jump in and correct me, because this does take me a little bit out of my wheelhouse. But one of the things I can say is that we have a lot of experience with that, because that was our reality too, right? And I think that what we saw in this country was similar in a lot of ways to what we see now in Brazil, which is that a lot of people unnecessarily got sick and passed away. And that is unavoidable in situations where you have real failures in leadership like that, because I think a crisis of the magnitude that we're talking about really does require large-scale leadership. It really, really does. And at the same time, we saw here, and I think we see this in places like Brazil as well, you see whether it's state officials or local leaders or community leaders, people step up. They step up and they take care of one another and they do the best they can. But I do think that it's a major, major impediment to have a leader who is actively undermining efforts to ameliorate things. I really, really do. So I don't have the most hopeful answer about that, except to say that even in those conditions, you see people working really hard and making a big difference. I don't know, what do you think, Lisa and Stephen?
Yeah, the only thing I would add, I think that's a terrific answer. I would just add that during this pandemic, we've seen community leaders step up, and people are taking control. They're empowered to change their communities, and so I think when you have a leader like that, you'll see people from the community emerge to take their power and oust their leaders. And it may take a while. And I know it's hard to do during a pandemic, but I think it's possible. Maybe the community will decide, like, we've had enough, and they'll take charge.
May I add a few quick thoughts? I know we're running out of time. Bolsonaro's perhaps the worst example of irresponsible and reckless nationalism. You could lump him together with some other people we're familiar with. You could lump him together with Orban, with Modi, and with former President Trump. So you have to imagine this is not a permanent feature of this catastrophe. Brazil is a catastrophe. It rivals India in that regard right now in terms of the nature of the pandemic. But where do you find hope? You find hope, as Lisa said, in the local response, in the local capacity. I think you find hope also in Brazil has exceptional public health capacity. It has a legacy of leadership globally and at home in public health. It has exceptional R&D scientific capacity. It's running highly sophisticated field trials on most of the major vaccines. And it has strong provincial authorities who are pushing back against the ridiculous policies of Bolsonaro. And they're fighting like hell in order to get the right policies in place and to cut deals externally where they can. So there's much that can be done. There's much that the United States can do to be supportive of those who are trying to do the right thing. And we can't possibly give up on Brazil because of this leader, and it's not going to be there forever, frankly. Thank you.
I'd like to ask one more question just to round it out. I know this will be more like a lightning answer because of our time, but specifically to the Colby College students who are watching, there are some who are interested in going to public health, some who are, citizen advocates and care a lot about working and supporting those who are from marginalized communities. So I just love to hear from our three experts, your last kind of 30 seconds or a minute advice to those college students who are looking at this topic, this pandemic, this last year, as they think about their careers and moving forward, and any advice that you have for them if you were in their shoes right now. We'll start in the order I think that we began. So we'll go Lisa, Steve, and end with Nadia. Lisa?
Yes, I would say, first of all, just follow your heart. It sounds trite, but if you feel you need to move in this direction, do everything you can to pursue that path. Public health is an incredible field. There's a huge need, especially for people who care about the community and being connected to community. And finally, I would just say, ask questions, you can probably reach out to any of us. You can certainly reach out to me. Ask questions so that you get a sense of what the range of opportunities are for you in public health.
Thank you. It's hard to go beyond what Lisa just said. We're in a moment, a historical moment of crisis and trauma, unlike anything we've seen, but it's exposed huge weaknesses in our public health system. And we're turning our attention to that. And our remarkable schools of public health, of which there are many in the United States, are filling up with talent today, which I think is inspiring and gives me a lot of hope and optimism that we're going to train the next generation of folks who are going to be very imbued with this experience and the desire to change things and rebuild, because we face a huge challenge right now. Our public health system at the local and state level is extremely fragile. It's decrepit. It needs to be reconstructed. The folks who run those programs are exhausted. They've been besieged politically. They're resigning in droves. They've been attacked, and they continue to be attacked by hostile legislators. And we need to get back on. This is one of the paradoxes of this, is that the public health field at the local and state level is under siege. Whereas when you look at universities, there's this enormous optimism and faith in this and wanting to move forward. So I would encourage you to all look at this and think about that. I think it's a wonderful period, difficult period, a tragic period, but a period of hope in terms of what public health will be able to accomplish.
Hard to follow that. I agree with all of that really beautiful advice. And I've been seeing firsthand just how uncertain this year has felt for all of you, and of course last year as well, and how difficult of a moment this is. And I've also seen like how resilient you've been, and how grateful you've been for the opportunities that we've had to be together and learn together, and that you've all been very well aware that not everyone has had those opportunities this year. And I am really taken by something Lisa said earlier about when you said something, Lisa, about, you know, we talk so much about why is it that Black Americans, African Americans don't trust the medical system, and you flipped it, right? And you said, no, actually, the system's not trustworthy. And so for me, I think what I would give as, you know, some humble advice is, and something that I'd like to join you in, and I know you have lots and lots of allies of all generations in this too, is how do we build a more trustworthy system? How do we actually do that? And for me, that involves addressing the determinants of health, the underlying inequalities and inequities that not only make the pandemic so much worse, as Stephen said earlier, right, that what we're seeing, these disparities come out of the underlying inequities that are already present, but also if we tackle those, then we'll live in a more beautiful and just world. And I know that sounds incredibly optimistic, but I really mean it. I think it's true. And I guess the last thing I would say is, if you're interested in health disparities, as much as we can, to let ourselves be led by the communities who are most affected, the people who experience these things firsthand and have incredible knowledge about them to share, and to look not just for the stories of suffering and disparity and stories of oppression, of which there are many, in which we absolutely must look at those, but also for the successes and the strengths and the joys, because there's a lot of that as well. Thank you so much.
Thank you, everyone. I want to extend a really deep and warm thank you to all the speakers for providing excellent answers to all of our questions. And I also want to thank the viewers wherever y'all are. And I hope that everyone can have a great night.